welcome everybody. And for those that continue to join us, pop into the chat where you're joining us from. But I'm Wendy Gerhard. I'm the Executive Director of Migraine Canada, and I'm happy to be moderating the webinar tonight on Psilocybin. I think I pronounced that right, probably not. And we have Dr. Alexander Melinyshin joining us as our keynote speaker. So welcome. And let's see.
Thanks for having me.
Let's try to proceed with my slides. And here we have, I need to acknowledge and thank all of the sponsors that make the webinars possible. So here it is. Without them, these webinars would not be possible. So we are gratefully thankful for their support. Tonight's agenda is going to be an introduction to Migraine Canada very quickly. I talk very quickly, so it won't be long. And then we're going to turn it over to our keynote speaker. And then we're going to have our presentation on Psilocybin. And then we're going to move into a Q&A. And we'll go through a little bit of that in a minute. Migraine Canada, who are we? We're a federally registered charity supporting all Canadians living with migraine and headache disorders. Our mission is to improve the lives of Canadians with migraine and other headache disorders through advocacy, awareness, education, research, and support. Watch out for more of our 2023 webinar series, including presentations on vestibular migraine, given by our chair of Migraine Canada, Dr. Elizabeth Leroux, and also migraine in children and teens, who will be hosted by Dr. Marissa Lagman in December. Also join us for upcoming Instagram live events given by Heba Hani, who is a pharmacist who is specialized in migraine. And we're going to do 2 more this year, and one is going to be in November on holiday stress triggers, and then also in December on weight and management, very timely to our festive season. Also, invite you to join our growing community at the website there below, and we'll include this in the follow-up email that will be sent tomorrow. We have an advocacy page where if you want to write into your elected official, your Minister of Health, your MLA, or your MPP, depending on where you live, and talk about your concerns related to migraine care and access to medication, we have a seamless, really, really easy way to do that, and we really encourage that. And last but not least, resources for migraine management. Check out our library. We have added a few more resources on GPANS and exercise. And we will be continuing to add to that library, so check into that regularly. Before we begin, our disclaimer: this webinar provides information and not medical advice. We note that all information presented and discussed might not apply to your own medical situation. Always discuss medical treatments with your own healthcare provider who knows about your medical history. And I'm going to now introduce Dr. Melinyshin. He is a neurologist with an additional subspecialty expertise in headache medicine and a member of the Canadian Headache Society. You'll often hear me refer to CHS in many of my bulletins and any videos that I produce, so it's the Canadian Headache Society. Dr. Melinyshin operates a community-based headache medicine and general neurology practice in London, Ontario. His current research interests, I'm trying to include cannabinoid, and I can't read the next word, and use in headache in patients, as well as the assessment of residency circular content pertaining to headache across Canada through the Canadian Headache Society. And I'm going to then stop my sharing and turn it over to Alex, who's going to start sharing and carry on with this amazing presentation that I'm sure everybody is very eager to listen to.
Perfect. Thank you, Wendy. All right. We're just going to swap over here. Okay. You got my slides, Wendy?
Yeah, we can see them perfectly.
Perfect. So we have been talking about this subject for a long time, and in neurology circles, I know it's a hot topic. It's an area where we don't have a lot of data. People are trying to do new studies, and we're making some promising gains. And, in Canada, at least, we're starting to see shops crop up all around where people are able to purchase psilocybin, and it may not be legal, but people are using it anyway, some therapeutically, some recreationally. And so it's becoming an increasingly important question in the headache clinic. And I think probably in a given week, and I only see headache, probably 3 or 4 times it will come up as a question. And so it's a difficult subject because it's not really Health Canada approved, and so we have to be careful about how we talk about it. Our goal tonight was to try to make sense of the information we do have, maybe pose some questions about where we need to look next, and kind of put together all in one place the information about psilocybin and how it's relevant for headache treatment, and give you some resources that you might be able to do some more personal research. So here we go. Disclaimer. Okay, so like Wendy mentioned, this discussion is not really an endorsement for personal use, but it's really a digest of my opinions and kind of distilling all the latest research trends for you. Psilocybin is considered illegal, so in many Canadian jurisdictions, use or possession can result in a criminal offense. These molecules, like psilocybin and the other hallucinogens, are molecules that are interesting therapeutically to doctors and patients. They're under investigation. We do have ongoing trials in a lot of different areas, but they still have yet to prove kind of concretely that they are very beneficial, and we still haven't mapped out really a lot of the side effects and problems that might arise with them. Again, like I said, it's really not yet approved by Health Canada, although, you may read in the news about certain exemptions in really extenuating circumstances. People who have, used psilocybin to help with the anxiety or processing end of life, in medical assistance in dying or palliative care, sometimes with refractory post-traumatic stress disorder, or depression that has tried multiple different things without success, as well as cluster headache. Psilocybin is a potent chemical, even though it's natural. Sometimes I get this feedback from my patients, well, it's natural. Like, how bad can it be? And natural doesn't mean it's weak. If it's strong enough to, shake up your brain and reform connections, it's probably potent enough to do some bad things if used improperly too. And one thing that I think really bears mentioning is, think of the number of Canadians on an antidepressant or using a serotonin-like medicine, including antipsychotics, maybe even triptans potentially, but less likely. When you combine them, you're really giving yourself a boost of serotonin, and this can be quite toxic. So there's that dreaded serotonin syndrome that can sometimes even lead to coma or death. So, I would say really you do, like Wendy mentioned, have to consult with your doctor, really talk about the risks and benefits of this. They're not going to be able to prescribe or recommend it to you, but, if you need to know more about the consequences, it's an important discussion to have. So that aside, onto the good stuff. So I wanted to show you some of these mushrooms because they're quite diverse. And psilocybin is a naturally occurring compound. These mushrooms grow all over Canadian forests. There's over 200 species of mushroom that do produce this chemical. And the interesting part is muscarine, which you might remember, that big red mushroom with white polka dots that's always in Smurf videos or something. That's Amanita muscarina. Muscarine is the ancestor of psilocybin, this molecule. It's very toxic, but can be used medically. And over 20 million years, probably, psilocybin has slowly evolved from muscarine into these mushrooms that we have today. And so you can see pictures like petroglyphs in caves of early people depicting in murals the use of mushrooms, even in kind of like religious type of ceremonies. In Mesoamerica, it's often used in religious practices by indigenous people. And so we have formal recordings of history by Spanish visitors in the 16th century documenting the use. So use goes well back in history to cave people and to various indigenous cultures through South and Central America. So what's being looked at currently in terms of research? There's neuroplasticity, which is that idea that your brain can form new connections and change the way it speaks to different segments. Intracellular signaling, which instead of connections between neurons, we're looking at within the cell, how do the different departments talk to each other? Functional imaging, which we'll get to in this talk, and it's a type of imaging that's not so much concerned with like tumors or bleeds or things like that, but it's able to tell us what parts of the brain are activating or connecting when we're doing something. And then the non-psychedelic congener. Like what is a congener? A congener is like a little component of an organic mix of chemicals. And the idea is like, what if we could find a component of these biologic mixtures where it has all the therapeutic effects, but maybe none of the negative ones, or we don't want hallucinosis, for instance. And so by either tweaking some of these molecules and studying them chemically, or isolating certain compounds from a mixture, we might be able to find a better tolerable medicine. Specifically for conditions, we're looking at headache. Cluster headache is probably the most well-known use for psilocybin, but migraine as well. Other chronic pain conditions like fibromyalgia, there's anecdotes that it may be important. And we're also looking on a biochemical level. So in terms of the inflammasome, which we talk about the whole sum of all the different inflammatory molecules around our body, chemical messengers that often mediate disease, and how else are these implicated in other things like mental health disorders? This is like a Gordian knot. All these problems like chronic pain, mental health, trauma, we're starting to see even through functional imaging studies that there are certain commonalities, there's nexus in the brain in certain areas that are bottlenecks, and perhaps this molecule might provide some insight into how we can unravel that. There's promising anecdotes about using these medicines for substance use disorders, whether it's alcohol or other recreational drugs. And then, of course, like I mentioned, in palliative care and medical assistance in dying, some really excellent stories of people who have been able to be at peace and come to terms with, these kind of very stressful life events. Another kind of thing that's actually just interesting from a basic neuroscience perspective is that studying the hallucinations and the psychedelic phenomena that come from these medicines also tells us about how the brain is wired and the underlying mechanics in terms of our perception. So solely from that perspective, there's probably a few people in the audience who have synesthesia, where you may mix, colors and sounds or tastes and things like that. And so these things, when you take a psychedelic, it tends to loosen those boundaries, and it's more common in average people. And so perhaps it can tell us something about the workings of the brain of the synesthete. And in general, there's an idea not just of trying to treat disease reactively, but being proactive and attending to your mental health in a prophylactic manner. Is there a role for this potentially in terms of well-being before we reach the point of disease? And I think all of these are very interesting lines of questioning. And we're really at the beginning of this journey, and I think there's a lot of exciting developments to be had in the next 10 years or so. So why psilocybin? Out of all the targets that we could pick, all the bizarre herbs in the jungle, why are we picking this mushroom? And in short, there's a lot of conditions that people are not happy with the current treatments we have. So they're either lacking in efficacy or they have a lot of side effects. Psychedelics in general are thought to have a favorable safety profile when you compare it to things like opioids, for instance, which are commonplace. And the other issue is that in the midst of an opioid crisis and an addiction and abuse crisis, psychedelics are thought not to have the addictive potential of these. And so perhaps this is a more viable avenue to explore when we're looking for substitutes for people who are suffering. In terms of the dosing, I would say it's highly variable. Everybody kind of has their voodoo if people are using magic mushrooms, and they'll tell you how they weigh it or dose it. Highly variable. We really need to figure out what is the optimal way to dose this in terms of the frequency, the amount of the substance, and then how it should be used on an ongoing basis. So, it can be used as a single oral dose in some studies, or there may be multiple intervals with different doses. Some studies look at ongoing microdosing, and this has become very popular, in online forums and colloquially, but it may have some potential adverse effects, which we'll get to in a second. Sometimes you'll hear people talk about macrodosing or the hero dose, which is taking a quite large amount, and that may have a different physiologic effect than, a slow, gradual exposure. Interestingly, in studies, psilocybin can be purified and put into solutions, so it can be taken intravenously as well as taking it orally, and that may have a completely different effect too, because you're bypassing your metabolic organs that sometimes would tweak the amount you're getting. So the psychedelic effects probably occur with doses that are between 4 and 10 milligrams, and recreationally, though, people are taking much higher doses, sometimes 10 to 50 milligrams. The typical effects usually start to show up about 10 to 40 minutes after ingestion. And for those of you with experience with other edibles like cannabinoids, it does depend on what you've eaten and if you have gastric motility problems, gastroparesis, those kind of things. And so the effects can persist for up to 6 hours and in some cases more. And that's just in terms of the immediate kind of psychedelic effects. But as we'll see in this presentation, there may be other changes in brain neuroplasticity and other persistent changes that may last even a month or beyond. So I wrote here, there's a slide here of these mushrooms, and this was taken from Emanuel Schindler, who is a prolific psilocybin researcher down south. And she presented at one of the American Headache Society meetings about her research, which we'll recap here. And I just wanted to show the different kind of dosing algorithms. And I wrote here the low dose. I think in the beginning days, we're trying to do proof of concept studies. We're trying to demonstrate safety so that we can have a solid ground to do more, larger doses, longer studies. We're using very tiny doses of 0.143 milligram per kilogram. So, it ends up being quite low. So microdosing. This is probably the hot topic that, you'll hear everybody talk about if you have friends who are using these things recreationally. Basically, it is this self-administration of tiny doses of mushroom, and it's allegedly not at doses high enough to impact regular functioning. But, I would argue this is the same kind of thing we heard about cannabis. Oh, it's not centrally acting, and yet you're saying it's an antidepressant. If it's causing changes in pain processing, reprocessing trauma in your mood, I mean, it's impacting your functioning. So I think it really, it depends what you mean. We got to be careful about how we define these things. Early research shows that even the low doses that do not provide a hallucinogenic effect may still have therapeutic value for other conditions like panic attacks or headaches or things like that. So, there's a promise that, perhaps at very low controlled doses, you may not need to have a chaperone or someone to watch you take these small doses. There is a concern, though, because psilocybin belongs to a class of medication called the indoleamine hallucinogens, and this includes other things like LSD and things. There is some activity at a specific serotonin receptor, 5-HT2B, and there have been other drugs like methotrexate, other types of agonists that have been shown to link to valvular heart disease and cause fibrosis. And this can lead to pulmonary hypertension, cardiac issues, potentially reduced quality of life and mortality. So, that to me is quite concerning. And so then we start to generate interesting questions. Should we be just pulsing this one time here and there, or should we be doing chronic low-grade exposure? Does that increase the risk? The truth is we do not know. We just don't know. And that's why formal studies are needed. It's not that people are trying to withhold promising therapeutics, but there's a reason we proceed very carefully with these kind of trials, because we do really want to minimize the amount of risk we expose people to. Like I mentioned, there are congeners, these kind of non-hallucinogenic versions of molecules that may still have the therapeutic benefit. And there's some exciting ones. This BOL 148, which is a congener of LSD, is under development, and it's shown some promising therapeutic effects. So I wanted to show you this interesting diagram, and you don't have to be an organic chemist to get it. Psilocybin, this is the molecule here on the left. When you ingest it, is rapidly metabolized down to psilocin. So you take off some of those extra groups there up at the top, the phosphate, and then maybe you gain an extra hydrogen on your nitrogen. What that does is it turns psilocybin, which is really not active biologically, it turns it into psilocin, which is really the agent that's giving you all the receptor effects and causing the psychedelic and therapeutic effects. Now, just for comparison's sake, I want you to look at serotonin, melatonin, and the triptans. These are all molecules that are implicated in neurotransmission and especially important for migraine and headache pathways. Triptans work for migraine and cluster. They share a common shape. So you can see there's a benzene ring and a pyrrole ring, which is a little pentagon, and then a tail with the nitrogen. So all these molecules have some, we call it homology. They look the same, they got the same shape. And what that means, if you think back to Fisher-Price bucket, there's some that are going to be able to squeeze through the holes and some that are not, and they have different activity at different receptors. So you can think of it like the most confusing, terrible Fisher-Price bucket, because that's pretty much what it is. Just for the sake of comparison, I think it's noteworthy that DHE Like for those of our migraineurs who have had lots of experience and have been suffering for decades, they may have been exposed to DHE. It can be a wonderful drug for some people for migraine. But DHE also has activity at the receptor we think is the primary target of psilocybin. This is the serotonin 2A receptor, 5-HT2A. And in addition to a number of other receptors. But, I think, again, we need formal studies to see if this is a shared mechanism of action in migraine between psilocybin and DHE or things like that. And that's going to take more study. So why does it work? Well, like we said, psilocybin is a prodrug. It's rapidly turned into psilocin in your body once you ingest it. And this is the active ingredient in the magic mushrooms that produces the effects. And the most important receptor, if you could take away one receptor, and I'll show you some just to give you nightmares because that's what I have to memorize, is the 5-HT2A receptor antagonist. And, interestingly, we think about the antipsychotics, some of our newer antipsychotic drugs, they are antagonists. So they're blocking that receptor. So this is, that's why you can think of like sometimes psychotic effects can be hallucinations, auditory or visual, and we block that to turn it off. Well, this is kind of the opposite. And so it's creating these kind of hallucinations. And it's primarily eliminated from the body by renal excretion to the kidneys. And the half-life is about 3 hours. I would say a good rule of thumb, if you want to totally clear a substance from your body, is 5 half-lives. So 15 hours or so. But I would say for the psychedelic effects, it's somewhere around 6 hours that will last. So just to show you a very brief overview, again, even this is kind of a gentle selection of the receptors. I tell you this only to show the complexity because, I spend a lot of time reading about this and it boggles my brain and I'm trying to break it down, but there's so much more that we don't know. And that's why I want to balance kind of the hope of having a new therapeutic agent, which I know many people are desperate for, against like jumping headfirst into the unknown because we're dealing with some pretty powerful brain chemistry here. So we're going to start with the 5-HT receptor antagonist. This slide for you is presented as a reference. It works at the 5-HT2A receptor, like we talked about. It works at the 5-HT2B receptor, which potentially has that risk for fibrosis in the heart valves. It works at the 2C receptor, which can affect mood, behavior, appetite, and other hormones. And it also works at the 1A receptor, which can help to kind of regulate your blood pressure and heart rate through a number of different mechanisms. And so, I think as we learn more about that, we'll be able to tweak different versions of it to have fewer side effects or to target specifically different activities of this medicine. Now, I show you these kind of ancient diagrams of the brain. A lot of people are familiar with the lobes. And I think even thinking about a classical neurology training, we all learn the lobes and everything the lobes do and different lobules and gyri and everything. But we don't really get the whole picture of modern neuroscience, which talks about functional connectivity. And so the lobes, talking about like one area of the brain does this does this, you knock it out with a stroke, you lose this ability. That's extremely reductionist. Like that, I feel really fails to grasp the complexity of your brain. And it's not doing you any favors to think of it that way. The other myth that I really absolutely hate is, and this actually comes up a lot, even from doctors, the myth that you use only 20% of your brain. That is not true. You use all of it. Your brain is a highly conserved, like evolutionary miracle, and you need every little piece of it. And you may not use it all at once, but you definitely use all of it. So if someone tells you that, you tell them I correct you otherwise. I want to show you this picture, which I thought was fantastic. It's an excerpt, a spread from Scientific American in 2019, and it's freely available on the internet. You can find it at the link below. And if you want to start delving into the real complexity of the brain, the 100 trillion connections, and how that actually helps us form consciousness and perceive the world around us, like it is a mind-boggling adventure. So I would encourage you to look up this article and start to read about it. So the way these scientists started to try to pick away at these systems was to look at areas of the brain, how they connect to different areas of the brain, nodes. What are the hubs, which are the areas that have a lot of connectivity to other groups of nodes? And then we look at the edges, which are the actual connections. And they ended up putting it together in terms of 7 main modules that help us process everything in terms of visual processing, attention, speech, and all these kind of things. And so like this is going to go well beyond the scope of our talk tonight, but I think, if you really want to start picking away the brain understanding itself, which is a really fascinating idea to me, this is a really great place to start, and they will give you good references to read more. And this leads us to the next topic, which is the idea of the functional connectivity of the brain. And so the brain is composed of these anatomically distinct regions like the lobes or the gyri, but they're functionally connected through a series of networks. And what that means is that, brains will activate in different patterns depending on the task you're doing. fMRI, which is the functional magnetic resonance imaging, and other types of scans can help us shed light on the dynamics of these networks. So if you're doing a particular task, you're going to use more sugar and oxygen in one area, and you're going to see that the metabolism changes, and we can measure these things to see which parts of the brain are active during which tasks. So it can also show us, interestingly, in a healthy brain, you can compare during different states and tasks. You can also make comparisons between brains in disease state and healthy brains. So in that way, sometimes diseases can shed light on how things are working. Now, there's this really important concept of the default mode network. And I would say this is a critical concept when it comes to understanding functional connectivity. And it refers to connections between brain regions that are responsible for everyday consciousness. And you're going to see it most when you're kind of in the resting state, just idling, kind of like your computer goes on the screensaver or something. And your overall neural activity, it shows a global decrease, and you reach this kind of baseline default activity. Now, the key areas for the default mode network are in areas of the cortex, which is the outer part of the brain, the bark, that are specifically related to emotion and memory. And, I think in the early days, we thought maybe it was going to be more important to be looking at sensory motor cortex, the sensation and motor action. But it seems that it's actually the emotion and memory areas that are most critical. As we come to understand it, we think that basically the pattern of the default mode network is responsible for your ego, or basically your sense of self and awareness, your internal and external representations. And we've shown that in various mental health conditions and chronic pain conditions, there are aberrations in the organization of the default mode network. And so this has become a very interesting way to look at the brain instead of just measuring things in the fluids or the spinal fluid or blood, or just looking at lesions of areas. As we come to understand the dynamics, how things move through time, we see there's a reason why we haven't been able to crack certain diseases like those, like chronic pain and in mental health. So I'm going to, again, blow through some really high level, crazy science language. I put these in with references so that you can look up these things if you want to read more. And then we're going to crack it down and make it understandable for everybody. So we talked about 5-HT2A being the main receptor that this works on to cause therapeutic effects. When you activate it, the neurons get very excited, specifically these pyramidal cells. And that means that the outer part of your brain, the cortex, it really changes the way it signals between different regions. And so it becomes completely excited, very irregular, very disordered, and they refer to that as high entropy. And then that state can be referred to sometimes in research as the primary state. The typical connections that you would see in your default mode network are broken down. And then all of a sudden, it's like no holds barred. They're connecting with everything. Really unusual, unexpected connections between tons of different parts of your brain. And that may even be the basis of synesthesia, where you interpret multiple senses overlapping and things like that. And then what's interesting is that, both immediately and in the long run, there's been studies that show that this changes the plasticity of the brain. So the dendrites are like the little fingers or branches on these neurons, and it changes the way they connect, the way they talk to each other, the way they express different proteins and grow. And so the theory behind this is that the new healthy functional connections will remain, and the dendritic plasticity will kind of sustain these even long after the psilocin has actually left your system. So it's creating changes that persist beyond the duration of the drug in your body. Now, the other observations they made were that taking psychedelics can reduce your neuron activity in certain areas and also reduce blood flow in certain areas. And so again, this may change different functional connectivity. And other parts like the insula. So insula is an area deep inside the temporal lobe. It goes in and it regulates your autonomic system, heart rate, blood pressure, but it does much more than that in terms of sensory processing. And so we see that in chronic pain conditions over time, you're going to have shifts in the areas of the insula that activate. And we're thinking that perhaps the psychedelics or psilocybin may able to reverse that, or perhaps create different patterns that may not, perpetuate that kind of chronic pain picture. So in English, please. If I had to give an analogy, I would say think of the brain like an orchestra. All these different parts of your brain are doing things individually, but when you power up to do a specific task, different patterns of the brain turn on or off in concert to get things done. And so in some disease states, it's like you have like the wind section is out of tune or something, and it's creating some discord. Psilocybin changes the way that the neurons talk to each other and can change the patterns in the way that parts of your brain connect to each other. It can change the amount of blood flow and brain cell activity in certain brain regions. And it can also calm down parts of the brain that seem to be important for chronic pain perception and emotional processing. And so I think that's probably the basis of why it's so exciting. Now, this graphic, for those who are more visual learners, I always like a good heat map. And you can see the red areas of this brain. You're seeing it from the inside. So if we split your brain down the middle and we open it up, this is kind of the inside of your brain. And the red areas have a lot more of concentration of those 5-HT2A receptors. So these are where they're strongly expressed. And if you look on the right, you can see that on the bottom of there, that little red tree-like thing, that's a neuron. And those little fibers are all the dendrites. And when you look at that graph to the right of it, it's kind of just chugging along at its normal activity. And then you give psychedelics, and then suddenly you see that it jumps up and it's just going up and down, up and down. It almost looks like a toothbrush there. That is the new excited activity state. And so again, when you look at the very top of it now, that kind of interesting ball of yarn thing, when you administer the psychedelic drug, you're seeing the formation of tons of new connections. And eventually that does reduce to some extent, but some of those connections persist long after the drug is used. So in this study, this is another one that was trying to answer the question, well, how long do these changes actually persist? They found that emotions and brain function are altered up to 1 month after a single dose of high dose psilocybin. And I think they got maybe like 25 milligrams per 70 kilogram. So, this is very promising, but again, only studied up to 1 month. Like perhaps the changes actually go even longer. And so this ball of yarn type picture is actually an interesting connectome. It's a way to depict all the connections of these different brain regions in a visual way that is a little bit easier to understand. And the 4 main sustained effects that they found in the study was improved mood for up to a month. And I'm simplifying this language a little bit. Less activation in brain centers that respond to strong emotions for up to a month. Changes in brain circuitry, some of them lasting up to a week, others were persisting at 1 month, depending on the region. And then they found many, many new connections between brain regions, some which did not exist previously, up to a month, and possibly longer. So the effects were observed well after the psilocybin had been eliminated from the body and beyond what you would expect just from activating the receptors alone. So how does this all translate into headache medicine? Like, why am I even talking about this as a headache neurologist? Well, here, please enter Emmanuel Schindler. She is like a star researcher in the field of psychedelics for both migraine and cluster headache. And she wanted to answer this question for migraineurs. And, so we started off, like I mentioned, with very low dose proof of concept studies to demonstrate safety and tolerability. And then we moved from there. So in terms of this initial study, we took patients between the ages of 21 and 65, 21 being, age of majority for substances and things in the States. And they had to have a confirmed diagnosis of migraine, episodic or chronic, but at least 2 attacks per week. And we did not include people who had a lot of significant medical diseases, which kind of made it difficult to give the psilocybin safely. Any psychotic or manic diseases because of their altered neurochemistry with the 5-HT2A receptor, as well as people who had active substance misuse or bad reactions to psychedelics previously. They also couldn't be, like I mentioned, the important thing is you cannot mix psilocybin with serotonergic medications. So these people were also excluded. They were given a very low dose of psilocybin. And this was a double-blinded study. So the patients, the subjects, and the physicians both did not know what they were going to receive at the time. We had a baseline collection of 2 weeks where we saw how many headaches they're having on average. And then if they did not qualify for the 2 per week, they were, dismissed. And then they were given a placebo first. So everybody who enrolled in the study was given the placebo, followed them for 2 weeks with diaries. Then at that point, everyone is given psilocybin. And so this is a kind of a unique trial design, and it's because each subject acted as their own control. Placebo was given first just because we don't want the potential long-term effects of psilocybin. I just told you it lasts a month or more. So we don't want that to confound the placebo period, because then it wouldn't really be a fair comparison if we had two groups crossing over. So then they were followed up even longitudinally up to 4 months to see how they were doing. The subjects completed the 2 experimental sessions, separated by at least 14 days, and we've already kind of covered how they crossed over. So the main thing that we were looking for here in terms of outcome measure was the migraine day frequency. And luckily, we did see both clinically and statistically significant reductions in headache days. But again, these are people who had kind of low frequency episodic headaches, perhaps like 8 to 10 or 12. And, but I still think it's extremely promising, even in a short-term study like this one. So, I'm really curious to see how the data are going to look in studies that have higher doses or are following patients for longer. We also saw reductions in the time to the next migraine attack. It didn't reach statistical significance for the first migraine, but perhaps for the second one and even extended later, we're hopefully seeing greater periods of latency in between attacks. So these are all very promising outcomes. But again, top right corner, look, only 10 people are enrolled in this trial. So, I mean, you kind of have to take it with a grain of salt. And even when things don't reach statistical significance, sometimes that's a function of having a tiny study, not that you're not observing a real effect. Oh, here we go. So side effect wise, what did we see? Nothing that reached statistical significance, but like I said, take that with a grain of salt. Main things to look for are lightheadedness, nausea, anxiety, maybe a little bit of paresthesias or dry mouth. But in general, like, it's extremely well tolerated. And even some of these things we see in the placebo group as well. So it's really hard to say. So let's summarize this up in a haiku format. I would say the single dose, low dose psilocybin was studied in people with migraine, episodic or chronic, over a short period, and we compared that to placebo. There was clinically and statistically significant reduction in headache days in the psilocybin group compared to placebo, and promising effects in terms of delaying the time to your next attack. The administration was safe and well tolerated, and the most common side effects we saw were lightheadedness, nausea, and anxiety. Limitations, like I mentioned, it's a low dose. Perhaps more is better, perhaps not. Small sample size, N of 10. Difficulty blinding psilocybin due to potential psychotropic effects. Many people say, well, hey, this is the subhallucinogenic dose. But there have been other studies that show even at those tiny doses, like, people feel altered. They can't quite put it to words, but they're aware something is different. Maybe that's kind of similar, like it's a positive version of brain fog or something. Something is off, but I don't know what it is, and it doesn't show up on the test. So I think there's some difficulty blinding psilocybin truly. The included subjects, we kind of lumped together episodic and chronic migraine, and we can go into a whole other debate about the arbitrary division of that. And also the brief duration of the study. So I think the results of the study are very promising. It's a good proof of concept. It's a good first step, but it looked at a very small number of people over the short term. So it's kind of hard for me to draw firm conclusions from this. But I think, like I mentioned, it's an important pilot study. We need larger, longer trials. We need to look at different dosing regimens in order to best determine how can we recommend this to patients in a safe way in order to treat migraine. Okay, on to cluster headache. So hopefully there's one or two of you in the crowd who have cluster, what it's like. But for the others, I would say this is one of the most debilitating headaches. And of course, migraine is debilitating, but they call this a suicide headache for a reason. It is one of the worst pains known, possibly. And our treatments to date, some of them are very effective. Some patients are very happy. But there are many that, unfortunately, despite all our charms, we don't have enough magic to help them. So enter clusterbusters.org. This website, I think, is an excellent resource for anybody living with cluster headache, and I direct all my patients there. And it was founded by, he calls himself a cluster head, who he really wanted to spread the word that, hey, I started LSD and it fixed my cluster headaches. And, so he started trying to connect people with cluster to hear about their experiences and things like that. And, I think it's a great place to discuss alternative therapies and hear other people's experiences. But again, I cannot stress enough, you need to always review any of these decisions with your physicians because, like Wendy mentioned, your medical situation may not be compatible with what they're recommending. So they decided after a while, when they had enough people, hey, let's do a survey and really try to get to the bottom of this. If we have, we're starting to build some basic levels of evidence, and then maybe we can use this as a rationale to get some doctors to do some trials. And they were able to get almost 500 people. Subjects were recruited from cluster headache websites, different headache clinics put up some posters, and it had 41 questions that looked at things like basic patient demographics, characteristics about their headache, recreational smoking and drinking, medications they're taking. And patients were able to subjectively attribute like a 4-grade scale of how effective they thought their treatments for cluster were. So about 650 people responded. Only 560 really completed the survey. And of that, almost 500 actually had a verified diagnosis by a neurologist or headache specialist. And this is important because we don't want to lump other people. Many people say, I have cluster headache or cluster migraine. What they mean is that they're having migraines that occur in clumps. But a true cluster headache is something very different. So these are the abortive medications that we commonly use to stop a cluster attack. And it shows their relative efficacies here. So patients were asked to rate them, whether they were completely effective, moderately effective, partially effective, or not effective. And I would say the subcutaneous triptan, sumatriptan by far is, the #1 winner here. But we also commonly recommend high flow oxygen, which people often even get in the emergency department or have tanks at home. And if you look at psilocybin, it was pretty comparable even to high flow oxygen, which is a mainstay. DHE, which is also commonly recommended, also ranked high in here. When we look at preventive medications, we often will start people on a prednisone taper or give a steroid nerve block. And then other things we use, like verapamil, a calcium channel blocker. It comes with, not insignificant side effects. Sometimes you need cardiac monitoring. There can be swelling or arrhythmias. And so when we look at psilocybin, it seems quite promising as a preventive, but so too do some of the other hallucinogens. In particular, I highlighted in red here that BOL, that congener that is non-hallucinogenic, people are using it, and it does seem to be quite effective for this. But again, it really has to be stressed that this is a molecule under investigation. Really, we do not know the long-term effects of this, so it cannot be recommended. So, non-hallucinogenic LSD conjugate bowl on par with psilocybin, LSD, and LSA in preventive efficacy? Maybe. And again, I think this is under study for now. So side effects, what did people report? Unfortunately, there's a response bias. Like a lot of people who are here to participate want to share good results because they're trying to advocate for this medicine. And so there wasn't a lot of mention of negative effects for these, but that could also be because they're generally well tolerated. And again, that's why we need formal study. So there were some headaches caused in one individual. Some people felt kind of sick or woozy, and other people got like irritable abdominal discomfort, but they also had a history of IBS, so it's really kind of hard to say. In general, psilocybin has low toxicity, relatively low harm potential, and true reports of lethal drug use are rare, but again, it's that combination with other medicines that can prove fatal sometimes. So what did we learn from this survey? In terms of those medications for cluster, they're probably comparable or more efficacious to most conventional medications, may be useful in aborting attacks, inducing remission, and prolonging remission. So one medicine can be acute and preventive. So like we talk about how magical that is for the GPANs for migraine, but this was already kind of a concept emerging here. And no other single drug class has been reported to have all these clinical benefits like this, especially for cluster. And I would say what was interesting was that even infrequent doses, people are just pulsing it with a large dose once in a while, and non-hallucinogenic doses at tiny amounts were reported to be efficacious. So, people said, well, hey, I don't have to take it very often, every few weeks or sometimes even twice yearly in some individuals. They felt that it had fewer side effects compared to what we usually recommend. And several participants said that even a single dose was enough to shorten a period or induce remission. And so I think, when you take all that together, and then it also has potential benefit for treating alcoholism, anxiety, or OCD, things that are often comorbid with these pain conditions. I think, it's a very interesting therapeutic potential. Limitations to this one, of course, it's an online survey, so, people are going to self-select. There's a survey bias. And certain populations are more likely to use mushrooms than others, or perhaps they are the ones who are medication refractory. Recall bias, sometimes people are more likely to recall positive events and report those than the negative ones. And, lack of diagnostic validity. They kind of clumped all the different types of cluster headache into one thing, even though they were said to be verified by a neurologist. But really, there's often confusion in the whole family, the spectrum of the cluster headaches, the trigeminal autonomic cephalalgias, like cluster, SUNA or SUNCT, or hemicrania continua. All these kind of things may sometimes be a little bit confusing, even though they shouldn't. There's overlap. And so, we really want to be precise when we do these trials so we can give you the best evidence. The other problem is it's quite subjective. Like, I mean, 4 tiers of efficacy is quite subjective. What is efficacious to someone may not be to another. I have patients that tell me that medicine didn't work at all. And I said, okay, well, how many days do you have of headache? And they went down from 30 to 15 days of headache. And they say that medicine is horrible. So, I think people have different expectations and goals, and that can be challenging in a survey. You can't, really guarantee purity in a survey like this. So, people are getting their mushrooms from all different places. Some are contaminated, some are already cut with other things. So it's hard to say. And many of the survey responders were taking multiple things at once. So, all of this was a very promising survey, and I think it helped lay the pathwork to get into, Dr. Schindler's next trials. But also, it had its own limitations. So, building on that, now it's time to do the hard work and really get into doing some controlled trials. So she wanted to do an exploratory study, to demonstrate, again, proof of concept and safety of this medication in cluster headache patients. And how did she do it? Well, again, like the migraine study, she's taken 21 to 65-year-olds. They had to have a confirmed diagnosis of cluster headache. And, we included both episodic and chronic cluster headache with cycles more than a 6-week duration for the episodic folks. And again, we excluded the similar people to the migraine study. Now, cluster headache is notoriously difficult to perform clinical trials for because, number one, it's super rare. So it's hard to actually find patients. Then when you find them, it's hard to find patients that actually want to take part in an experiment. And then number two, like the nature of episodic cluster is that, bam, it's gone as quick as it came. And so you're like, well, did that medication suppress it, or did it really actually do the trick and turn it off? And the only way you can answer that is with large trial groups so that you can truly prove statistically that there's a signal. So that's going to be a bit of a challenge. So what did they do? Again, they did that low dose cluster or psilocybin regimen, 0.143 milligram per kilogram, but they dosed it 3 times pulsed and separated by 5 days or so between. And again, this was double-blind, placebo-controlled, but different from the other one. It's not that they're receiving placebo at some parts. Some people were just in the placebo arm, and some people were in the psilocybin arm. So what they were looking for was the frequency of the attacks, the duration of the attacks, and the pain intensity. There were only 14 patients included in the study, 6 placebo, 8 psilocybin. And so, unfortunately, it's a little bit small that we can't always draw statistical conclusions. There did seem to be reductions in the psilocybin group across these things. However, we didn't reach statistical significance. But I think it's still a worthy signal that, we should be looking a little bit deeper. She broke down the 2 groups into episodic participants and chronic participants. Again, it's not powered to really look at the subgroup analysis. But what she found was that some people respond and some people don't, even within these categories. So, again, that goes back to the idea of like, when we make a clinical diagnosis, there may be multiple underlying causes, and some respond to one medicine and some respond to other. So the holy grail for this is to find some kind of blood test, some kind of imaging, where I can tell you if you're going to be the person who responds to this. So again, another area for research. What side effects did we have from this? Again, it's very similar to the other study. Lightheadedness, dizzy, nausea, anxiety, a little bit of fatigue and things like that here, but in general, very well tolerated. So summarizing this study in a couple sentences, we have a pulse dose here in this study, 3 times separated by 5 days, low dose, studied in people with cluster over a short period and compared to placebo. We saw reductions in the frequency of attacks, the severity of attacks, and duration, but it didn't quite reach statistical significance, still a promising signal. And the treatment effect between episodic and chronic was thought to be different. But even within these categories, some people responded while others did not. The drug was safe and well tolerated. And again, like I said, larger, longer trials examining different regimens for a longer time are going to be needed to really best outline the best treatment algorithm and how to minimize the side effects. Limitations: low dose, small sample size. In any pain trial, you're going to see very large placebo responses, so we have to make sure they're properly powered. And like I mentioned, it's difficult to blind psilocybin. And we kind of lumped again that diagnostic validity, lumping episodic and chronic cluster together. Um, when we're looking to the future now and thinking about, well, how do we design the next steps? I mean, they're already underway. I think Dr. Schindler has a number of irons in the fire, and other people are starting to get interested in this, and there's other studies in other areas. One major pitfall, especially in the migraine space, is our patient populations in these trials. Our current studies really aren't very diverse. Like, we don't need more studies only looking at 35 to 55-year-old white ladies from Wisconsin. It's great to include them, but we need people from different races. We need men and women represented. We need different ages. And if it's going to be able to generalize this advice to people in my clinic, I need to see my patients included in it. The stigma of psilocybin, I think society is getting better with this, after, winning kind of approval with cannabis. People are much more open to exploring what it means to use these medicines, and rediscovering ways that it can be done safely. But it's still considered a drug of abuse among many patients and professionals. And so it carries that stigma. There may be a risk to patients who are using larger doses. So especially in psychiatric settings or people who are taking large doses to do different types of therapy, and I think in those settings it's reasonable to have chaperones, multiple providers and psychologists who are present. But in tiny doses and headache, I think this would represent, like, making that mandatory would be an unfortunate barrier to trials in an area where we already lack a lot of funding to do this important work. The other thing is that as we start to study this and we start sharing our initial preliminary and positive results, as word spreads in the community, more people will begin to self-medicate. And that worries me in a sense, because although it may be generally considered well tolerated, there's potential for serious side effects. We don't know the long-term effects of chronic microdosing, for instance, or combinations with serotonin agents. The combination is not well known among the public, so there needs to be more public service announcements, and patient education. And that's what our goal, partially here tonight, was to share some of the pitfalls with you. The other problem is that there's a shortage of trained therapists. So specifically in the area of psychiatry and psychology, we don't have a lot of trained therapists there. And even in neurology and the other specialties who are examining psilocybin, there aren't many professionals who are aware of this, or who are interested in kind of using this as a potential agent. And so I think that will present a barrier to care for some people. And of course, this will be more prominent in academic centers where you'll have access, and people of lower SES or who live in geographic areas without, they're going to be the last to enjoy the fruits of this research. Like I mentioned, can psilocybin trial be properly blinded? I think we'll have to look at other ways of making sure that our placebos are truly blinding. And the last point I want to make here is that, while these small sample size pilot studies, they are very promising, but the caution has to be exercised because of the large placebo response that we see in pain and mental health research. And so even some of the studies that compared psilocybin to antidepressants and things like this, the effect size, it's hard to say. Like, it may be very comparable to placebo in some instances. And this is why we need properly defined trials. So, summing it up for you all, psilocybin is a psychedelic compound most commonly found in magic mushrooms. We have anecdotal evidence and early proof of concept studies, and they're showing a potential role for this in headache disorders like cluster and migraine, as well as other conditions. The current treatments that we have, they help some people very well, but they don't help everybody, and they may result in side effects or may not be helping others. Psychedelics in general are thought to have a favorable safety profile. It's not completely benign. But when you compare it to things like opioids, there's a certain benefit to going down this path. We also think that they are not likely to have the same addictive potential of opioids. Now, that's not to say they may not be habit forming or cause other behavioral changes, but we don't think you have the classic kind of withdrawal that you might see with opioids. Like I said, I'm going to harp it again and again. We need large, well-designed, randomized controlled trials. We got to prove the efficacy, find the optimal dosing, and we need longitudinal observation so that we can really identify the risks and try to get ahead of them. So, one last time over the disclaimer, I think it's good just to remind you, not an endorsement for personal use. This talk is merely my opinions on the research that is coming out to date, and I wanted to kind of put it all together in one place so that headache sufferers would have a platform to try to do some more personal research. Psilocybin is illegal in many places in Canada, and use or possession can result in a criminal offense. These are interesting molecules with a lot of promising therapeutic potential, but they're still under investigation, and we haven't quite proven their efficacy. It's not yet approved by Health Canada, and it's a potent chemical. Like I said, just because something is natural doesn't mean it's safe. Snake venom is natural. It can do terrible things. Everything in the right amount. It needs to be properly studied. And if you mix it with serotonergic medications, antidepressants, antipsychotics, antiemetics, just to name a few, you can result in very serious side effects. So it's important to talk to your doctor. And with that, I want to thank you for your time. And we've got a healthy chunk of time for questions.